Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adewuya. Today, I am joined by Dr. Melody Smith, who is a board-certified medical oncologist and hematologist at Stanford University, where she serves as an assistant professor in the Department of Medicine, Division of Blood and Marrow Transplantation and Cellular Therapy. A nationally recognized expert in CAR T-cell therapy, Dr. Smith leads a translational research lab investigating how intrinsic cellular mechanisms and extrinsic factors like the gut microbiome influence the efficacy and toxicity of cellular therapies. Her pioneering work has uncovered critical links between antibiotic exposure, CAR T therapy outcomes, advancing the conversation on antimicrobial stewardship in immunotherapy. Clinically, she cares for patients undergoing bone marrow transplantation and cellular therapy, and she is deeply committed to improving access, safety, and long-term outcomes for patients with hematologic malignancies. Through her research, mentorship, and clinical practice, Dr. Smith is helping redefine the future of immune-based cancer treatment. Dr. Smith, thank you so much for being on the podcast today.
Thank you for the invitation and the opportunity to share a little bit about our work.
For clinicians who may be familiar with the term, but not the latest applications, how would you describe CAR T-cell therapy and how it's evolved in recent years?
CAR T-cell therapy, or chimeric antigen receptor T-cell therapy, is a type of cancer immunotherapy that is indicated for patients with relapsed or refractory malignancies. The current regulatory approvals from the FDA are for patients with hematologic malignancies or blood cancers, but there's also a lot of work that's being investigated for patients with solid tumors, assessing both targets for CAR T-cell therapy as well as the optimal ways to administer these therapies. In terms of manufacturing or developing CAR T-cell therapies, they are isolated for the most part from a recipient with an underlying cancer. These would be autologous CAR T-cell therapy, so from that patient or self. These cells are then brought to the lab where they're introduced with a receptor that allows the T cell to recognize an antigen on the tumor. These are receptors that are not native to the T cell, and that's why it's called chimeric. It's a receptor that's foreign to the T cell, introduced into the T cell with the approach being that it's going to target the tumor in a more antigen-specific fashion. This has really revolutionized hematologic malignancies, and I think more to come in the solid tumor space.
You've provided a great overview of where CAR T started and how far it's come, not only in indications, but also in the engineering. As these therapies become more refined, I imagine that also shifts the clinical decision-making. Can you walk us through how that evolution has changed the kind of patients being referred for CAR T today, and how has that shifted from when it was first introduced?
From the time that CAR T-cell was first introduced, the initial indication was for pediatric B-cell acute lymphoblastic leukemia. And now the indications encompass both CD19 positive malignancies, B-ALL, as well as non-Hodgkin's leukemia. There are 5 FDA-approved CAR T-cells across those 2 indications. And there are 2 FDA-approved CAR T-cells for multiple myeloma. From the perspective of evolution over time, how CAR T-cell indications have changed. First of all, there are more diseases that are approved for their use. Additionally, their approvals encompass both pediatric and adult populations. From the perspective of CAR T-cell, where it presents in the order of therapy, there are CAR T-cells that are approved as second-line therapies, and then ones that are approved for later lines for patients who have relapsed additional lines of therapy. Certainly, CAR T-cells have moved a little bit earlier in the treatment process, but there are no frontline CAR T-cells that are approved for cancer treatment as it stands. That can continue to evolve and likely will change over time. Those are some of the ways in which the FDA-approved CAR T-cells have evolved. I think also what's really exciting is some of the work that's being investigated in the preclinical stage, early stage clinical trials that are looking at CAR T cells from not only autologous sources, but also donor or allogeneic sources. CAR T cells, not just from conventional T cell sources, but also from non-conventional T cells, such as gamma delta cells or NKT cells, as well as using genetic engineering with CRISPR and other strategies to engineer CAR T cells. There's really been such a robust groundswell of investigation of this therapy because of the therapeutic promise that has been observed. And so I think that'll continue to reveal itself over time.
Can you talk a little bit about this question as it relates to the referral criteria due to toxicity risk?
The specific toxicities that we evaluate for that are CAR associated toxicities predominantly present within that acute setting within those first 30 days after CAR T cells. We are much more astute and able to not only diagnose these at an earlier stage, but also treat them. Even though these toxicities can present morbidity for some patients, they're much better managed than when we first get in CAR T cell therapy in the clinic. The other thing that we've gotten better as a field at over time is trying to differentiate which patients would be a better candidate based upon the therapeutic and toxicity profile. Patients who are older or maybe have more comorbidities might be recommended to receive a certain product that has a more modest toxicity profile than another.
I appreciate what you said that there is this increasing nuance in how you evaluate fitness for therapy. I'm hearing also that there is complexity in patient selection, balancing the potential benefit with clinical risk, especially in patients. How do you typically approach these discussions with patients and their families about the risks and benefits of CAR T, especially those that might not exactly fit the eligibility criteria?
When we have patients who are a little bit older in age or who have notable comorbidities where we really want to ensure that do no harm and balancing benefit versus risk. In those patients who you see that we just have a conversation very openly. These are the CAR T cell products that are available, but we would recommend this one for this reason as opposed to that one. We recommend to them based upon these various factors, including toxicity. And generally, patients understand that we're giving our best recommendation to them so that we can see the benefit from the anti-tumor side of the CAR T cells without a prolonged hospital stay with various complications. It's usually a very open conversation, and patients understand our experience and expertise that plays into those recommendations.
I imagine part of that conversation is also about the logistics of their caregiving needs, post-treatment monitoring. Do you also talk at that time about exploring clinical trials with the patient?
From the perspective of clinical trials, anytime a patient's referred to us for a CAR T cell, so let's say, for example, a given patient with diffuse large B cell lymphoma, we always present to them at the time that we're discussing CAR T cells, both the FDA approved CAR T cells that they would be candidates to receive, as well as any CAR T cells that we have available on clinical trial that we screen them for. So we present them at the same time with the transparency that clinical trials, and we may have a certain amount of data or very limited data to share with them, but we provide with them the rationale as to why a clinical trial might be a good fit compared to a commercial product. But that is always mentioned in our discussion with patients if there is a trial that they're eligible for.
What you're saying, it's ultimately about the shared decision making that you have with the patient and a very personalized discussion around all of the components that you just talked about, the goals of care, what's available in terms of clinical trials, and what available data that you have.
Definitely. And I would say that CAR T cells are a potentially curative approach. All of that conversation is taken from that perspective that we're trying to give a therapy that has a potential for a long-term durable remission for patients and the potential for cure such that they may not need to deal with their cancer again or for a very long time. And so that nuance is really important in terms of developing each patient's treatment plan. An important piece of CAR T cell therapy and cellular therapies that we administer here in the bone marrow transplant and cell therapy division, which is that it's a very multidisciplinary approach to treatment involved from the first day social workers throughout the hospital stay, both with physical therapy, occupational therapy, our advanced practice providers, and all of these pieces together help to care for the patients. All of these pieces come together as we're designing a treatment plan for our patients.
CAR T has really transformed outcomes for some patients, but it's not a panacea. What are some of the biggest hurdles scientifically or clinically that you think we're still trying to overcome?
Relapse is a really big risk for patients who receive CAR T cell therapy. About 60% of patients still relapse. with many of those relapses happening early. When we look at the long-term data for patients who've received CAR T-cell therapy, the first 12 and I would say even 18 months is when many of those patients who are going to relapse, with later relapses beyond that time point being much more rare. We know some of the mechanisms for relapse, whether from the tumor side, the tumor losing or downregulating the antigen or the marker on the tumor that the CAR is targeting. Another aspect of relapse that a lot of folks are investigating is the T cell fitness. So, what T cells are going to be the ones that are going to best persist, not lead to T cell exhaustion from the immunologic perspective. One of the areas that my lab is really focused on, both from the clinical side, but also more so in the lab, is endogenous factors within the host, the intestinal microbiome, and understanding how that is a factor that may modulate CAR T cell response.
You've highlighted some of the critical challenges that gets overshadowed by a lot of the excitement around CAR T success stories, but also some of the innovations that have come up through those challenges as well. On the clinical side, we've also seen significant strides in how we manage toxicity. In your practice, what advances in toxicity management have made the most significant clinical impact?
There have been some really nice studies from the clinical trial perspective that have looked at prophylactic treatments to mitigate or decrease the severity of toxicity. From the clinical perspective, I think those have had a really notable impact. Also, both clinical and preclinical studies that have helped to elucidate the cytokine and inflammatory profile that is associated with various CAR related toxicities. That's also been very instructive for us to not only understand more of the pathophysiology of these toxicities, but also the targeted therapies that we can use to treat them. For an emerging toxicity that we've seen called immune effector cell-associated hemophagocytic lymphohistiocytosis, which is like a HLH type syndrome that can occur after CAR T cell therapy. Really, research from various studies has illuminated what is that inflammatory profile and what are the laboratory and inflammatory markers that we need to monitor in that setting. As a result of that being seen across various clinical trials, we now have a consensus scoring and assessment for that therapy. Various researchers across different institutions using CAR T cells coming together with their insights in the clinical scenario has helped us to be able to manage these things better for our patients.
That kind of precision in response management has likely made a meaningful difference, not just in outcomes, but really in the overall patient experience. I want to shift to talk a little bit about the work that you're doing in your lab and the gut microbiome. Most clinicians know that the gut microbiome matters in general health, but how did it become such an important piece in CAR T?
In terms of in general health, there's a lot of discussion of the gut microbiome in popular literature. People are intrigued by it. And I think it is an area that is diverse, so complex, and still there's a lot that we need to investigate to understand it better. The gut microbiome has been implicated across a range of diseases, not just in cancer, but specifically in cancer. Over the past more than a decade, there's been emerging data in terms of the gut microbiome and the response to various chemotherapeutic agents, but specifically for cancer immunotherapy in the fields of allogeneic hematopoietic cell transplantation and also for immune checkpoint block, for example, with anti-CTLA4 and anti-PD-1 agents. There's been a lot of data characterizing in clinical cohorts and also in preclinical models that the intestinal microbiome, the bacteria, the fungi, and even the viruses that are within the host play a role in various outcomes following these therapies. I became intrigued by this research question and started collecting samples from our patients who were receiving CAR T cell therapy. And in collaboration with the University of Pennsylvania, I was at Memorial Sloan Kettering at the time that I started this research. We published the first study that highlighted that the intestinal microbiome is correlated with responses to patients who receive CAR T cell therapy. And in our study, we focused on patients with non Hodgkin's lymphoma and B cell acute lymphoblastic leukemia, characterizing how antibiotics prior to CAR T cell therapy lead to worse outcomes, and also profiling specific bacterial taxa that were correlated with CAR T cell response. So from there, that paper was published about 3 years ago now. And from that time onward, there have been subsequent studies that have validated several of our key findings and illuminated additional insights as it relates to the intestinal microbiome and CAR T cell therapy.
I want to touch on what you mentioned towards the end of your response around antibiotics. And you and others have shown that antibiotics given before CAR T can influence outcomes. Can you explain the mechanisms or the hypotheses behind that connection?
For the antibiotics, we looked at 4 weeks before CAR T cell therapy. Subsequent studies have looked at 3 weeks before, and another one has looked at six, and found that exposure to antibiotics in the weeks before CAR T cell therapy, just any antibiotics, is associated with decreased overall survival and progression free survival after CAR T cell therapy. Because not all antibiotics are equally disruptive to the gut, we in our study and others have honed in on a subgroup of antibiotics that we classified as obligate anaerobe targeting antibiotics. These are antibiotics that disrupt commensals in the gut that are obligate anaerobes. And we found that exposure to these antibiotics, and they're antibiotics that we're all really familiar with, piperacillin tazobactam, imipenem, meropenem, antibiotics that are given to patients who have neutropenic fever, predominantly before CAR T cell therapy. We found that exposure to one of these antibiotics was associated with even a more profound decrease in overall survival and progression-free survival. Likely, our hypothesis is that the disruption or loss of these commensals, the obligate anaerobes, is what's mediating that. In my lab here at Stanford, we are mechanistically now interrogating how these bacterial taxa and how the various pathways that they utilize, how this is directly impacting CAR T cell therapy. We not only found that exposure to these antibiotics was associated with decreased overall survival, but we also found that antibiotic exposures was associated with increased neurotoxicity, one of those toxicities that we were talking about before. So that's something else that we are analyzing mechanistically in our preclinical models.
The level of interaction that you talk about between the microbiome and immune cell function really adds an entirely new layer to how we think about pre-treatment care. What I'm hearing from you is that the antibiotics that we choose days or weeks before infusion can shape outcomes. That really challenges some of our traditional approaches to supportive care. What are some practical ways you think antimicrobial stewardship can or should evolve in CAR T programs, especially for teams that may not yet be incorporating this into their decision-making?
The word of caution that I always have whenever I'm discussing this data is that what our findings suggest is not that antibiotics should not be administered before CAR T cell therapy, but that, to your point, antibiotic stewardship is really important and critical for us to consider moving forward. Exposure to cefepime, which is also a broad spectrum antibiotic that's usually given for neutropenic fever, was not associated with decrease in overall survival or progression-free survival. And cefepime does target obligate anaerobes, but not to the same degree as those other obligate anaerobe targeting antibiotics that I mentioned. And so going back to the point of antibiotic stewardship, if a patient has a neutropenic fever or a fever before CAR T cell therapy and they need a broad spectrum antibiotic, cefepime may be a better choice compared to piperacillin tazobactam. We're already having some discussions internally as to how we can really refine and streamline our approach to management of fever in patients who are getting CAR T cell therapy. And so I'm hoping that we can come up with some uniform approaches to manage this, especially given the really strong and now reproducible data that's been seen across different clinical cohorts.
Sounds like we need a paradigm shift to think about not just new protocols, but really a new mindset, especially among infectious disease, oncology, and pharmacy teams. Let's talk about innovation on another front, donor-derived CAR T cells. What do you see as the clinical future for these quote-unquote off-the-shelf approaches, and how might they reshape the current CAR T landscape?
I think of donor-derived CAR T cell therapies as a really important aspect of future innovation for next generation CAR T cells in two streams. First, as a transplanter, it's really interesting to consider the potential of CAR T cells to be added following allogeneic transplant. That was also some of the work that I did during my postdoc. And here at Stanford in our bone marrow transplant and cell therapy division, we've really innovated and translated that to a clinical trial that is led by Dr. Lori Muffley as the principal investigator, in which, following an allo transplant, we're giving CAR T cells again as a strategy to decrease relapse, because relapse is a significant issue after allo transplant as well. And it's a leading cause of morbidity and mortality even after an allo transplant. So what we do is we have a graft engineered allo transplant. Then after that, give CAR T cell therapy. And we have a trial that's open, is now completing accrual for patients with high-risk B-cell acute lymphoblastic leukemia and has shown really promising outcomes. We do plan to continue with another study that's going to be investigating that for donor-derived CAR T cells using donor cells after transplant to improve outcomes. Then there's the off-the-shelf strategies, as you mentioned. We're really interested in those that can incorporate genetic engineering or alternative donor sources for T cells from non-conventional T cells. There are a lot of reasons why donor cell therapies could be really revolutionary for the CAR T cell field because you have cells from a healthy donor that might just be more fit. Having a bank of readily available cells will potentially help to drive down costs because right now CAR T cells are by definition a bespoke therapy because they're engineered from the patient. We could also obviate or just shorten some of the delays that we currently have with the manufacturing of CAR T cell therapy. The manufacturing timelines have already decreased in size in the autologous setting compared to where we started, but still off the shelf or donor cell therapies could further improve upon that. There's a lot of promise in the allo and off the shelf space that me and others are investigating now.
It sounds like there's an ability for off-the-shelf CAR T cells could potentially democratize access to the treatment, but I imagine that there's a lot of nuance in managing the immunologic risk when you're moving from autologous to allogenic products. What are some of the key immune-related challenges that your team is focused on solving? How close are we to clinical scalability?
Some of the biggest risk when you think about any allogeneic, specifically T cell therapy, is graft versus host disease. So, where the T cells from a donor inside the recipient may recognize various aspects of the recipient as foreign and can attack organs. Another issue could be rejection of those donor T cells by the host immune system, leading to a loss of persistence or just basically clearance of the cells. That's another big issue. From the perspective of how close are we to translating that, we've already translated some preclinical data with the donor CAR T cells after allo transplant to this phase 1 clinical trial, which I'll say has shown really promising results. And then on the side of non-conventional T cell sources or genetically engineered T cells, there's a lot of early stage clinical trials and even companies that are looking at this with varying levels of success.
What you've described really speaks to the level of engineering precision that is required, not just in targeting the cancer, but in modulating the cell's interaction with the host. These kinds of innovations are really making CAR T more accessible and adaptable. But I'm curious, is there a piece of the CAR T puzzle that you feel isn't getting enough attention right now? Something that's quietly limiting success behind the scenes?
I actually was going to answer the opposite first. Something I haven't mentioned, which is in vivo editing or engineering of CAR T cells. There are some early studies that are giving essentially CAR T cells in such a way that they're being engineered inside the host. And I think there's going to be some exciting data. Other things that are limiting engineering of CAR T cells, I think there's a lot of work being done in that space. One of the key limitations from a non-engineering perspective is there are a lot of patients who have these diseases, lymphoma, leukemia, that are not currently getting access to these therapies because of a lack of feelings from their primary oncologist that they would be well suited for it. And then there are also various social factors that maybe patients aren't being referred given concern for cost or the way in which CAR T cell does require for patients to be within the treatment center. So there are various things, I think, in terms of education, providing more of a knowledge base as to the actual therapeutic plan, as well as the support that can be provided to patients who are getting CAR T cell therapy that is limiting patients from being more broadly referred to centers that can administer this treatment for them.
As CAR T therapies become more mainstream, what policies do you think need to evolve to ensure equitable access across populations?
When CAR T cells were first FDA approved, we didn't know exactly how to detect the toxicities as early or treat them as effectively. There were a lot of guardrails placed around how we administer CAR T cell therapy, which I think were very important because we want to make sure that anytime we're rolling out a new therapy, that it's done in a way that's safe for patients, that clinicians can manage it, and that the right folks who know how to manage potential side effects are taking care of those patients. Now that we have several years of experience with these therapies, going back and reevaluating those therapies that have less severe toxicity profile, trying to understand whether a 30-day requirement of being within the treatment center is still absolutely necessary might be valuable. And that would probably need to be done on a case-by-case basis with experts and regulatory bodies, et cetera, that would help to open up the therapy to a broader population of patients. Patients have to have a dedicated caregiver. Not only do they have to move, but also their caregiver has to be with them. And that is a limitation. That's a huge factor that can be impacting who is getting to see these therapies and who is receiving them.
I'm also curious about whether the landscape has changed in terms of clinical trials and the population that is being included in clinical trials to CAR T. Have you seen a shift?
I can't say that I've necessarily seen a shift, but I can see that there's more intentionality in trying to ensure that the patients that are enrolled on the clinical trials are representative of the populations that are impacted by the diseases. So that is encouraging. That could lead to some more demonstrative change over time. There's just even more consciousness around the fact that we need to have a representative population. And so that gives me a lot of hope for the future.
It's a powerful reminder that the science can be transformative, but only if we have the systems that are in place to deliver it equitably to the population. How do you see cellular therapies and microbiome science reshaping how we think about cancer treatment in the next 5 to 10 years?
Cellular therapies, I'll start with that first. Cellular therapies have so much promise for reshaping the care of patients. When we think about cellular therapies, there are now 2 cellular therapies within the past few years that are approved for solid tumors, not CAR T cell therapies, but one FDA-approved tumor infiltrating lymphocyte therapy or TIL therapy. More recently, there is an FDA-approved T cell receptor therapy that's approved, respectively, for melanoma and sarcoma. Cellular therapy is going to continue to advance for patients with cancer, but also for patients outside of the cancer space for autoimmune diseases. There is a lot of work on CAR T cell therapy for autoimmune disease, which we haven't touched on today, just to keep our scope more refined. But I think as we move forward in the next few years, there may be some interesting approvals in that space too, because already the preliminary data has shown some promising outcomes for patients with various autoimmune diseases such as lupus or systemic sclerosis. And then for the gut microbiome, one thing that really encourages me is that now in the field of cellular therapy, there is data in distinct clinical cohorts showing the relevance of the gut microbiome to clinical outcomes, both the safety and the efficacy. In the future, I think we're going to see more studies looking at mechanism and refining what is the mechanism for these microbiome associations, and also developing tailored interventions, whether through bacterial taxa or metabolites. Now that we have a strong base of clinical data that supports delving deeper into mechanism, we're going to see that in the coming years as well.
There's such a sense of optimism in what you just said and that vision, one where we're not only refining the tools, learning more about the mechanisms that we use to treat, but also rethinking the ecosystem in which those tools operate. It's very clear to me that your work is helping to define what that future might look like. So, Dr. Smith, thank you so much for sharing your expertise and giving us a little bit of a window into the evolving science and clinical practice of CAR T therapy. And for our listeners, I hope today's conversation sparked new questions and ideas about how we deliver precision care in an increasingly complex therapeutic landscape. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.